are a little bit sideways. There's not everything that's gonna apply for normal children is gonna apply for special children. Some things are gonna be different as far as the way they work. Some things aren't going to work at all. But we're gonna kind of try and guide you through that so you have a little bit of an understanding of what's going on. We're gonna start off with some advice. First thing is that knowledge is the gateway to everything, and understanding is the key to knowledge. I'm going to be talking about a lot of very specific things with Kyrie, and that's going to be great if you ever handle her. But a lot of the things that apply to her aren't going to apply to everyone else. So understand the basics of what I'm talking about, and you'll be able to apply this to anyone. But only the specifics will only apply to Kyrie. The other advice is to become an expert in something. That's why I'm up here in front of you right now, because I became an expert in my daughter. But what you'll find in EMS is that people get hurt in all sorts of varieties. And anything that you do, probably somebody's going to get hurt in it. And if you're an expert in it, then that means that you have a good idea of what you can expect when you get into that situation. So just take whatever you're currently interested in and go with it a little bit further. Over the course of the next little bit, we're going to talk about Kyrie. We're going to talk about complications with delivery. We're going to talk about time in the NICU. We're going to discuss her current medical history, which we're going to cover epilepsy, the apnea monitor, G-tube care, challenges with ASD or autism spectrum disorder. We're going to talk about pulse oximetry and what you can expect with special needs parents. And actually, this is a picture of my daughter right up here. You can't see it because she's actually right there underneath my girlfriend's hands. And you might think, she doesn't look very pregnant. Well, she wasn't. And this was taken just a couple of days before we gave birth. Everything went pretty normal for our pregnancy until we went to 19 weeks gestationally. We had our anatomy scan. It's where they go in, they make sure that she has a spinal cord and she has a brain and her lungs are looking good. They take measurements. They look at everything to make sure everything's progressing nicely. And that's actually the first time you get a good picture to be able to determine the gender of the baby. We went through, we had the gender, we knew it was a girl, we knew it was Kyrie Rose. That was the first time we knew that. And everything looked perfect until they did the transvaginal cervical ultrasound. And what we found was that it was actually 3 centimeters dilated and that the amniotic sac was bulging into the birth canal. We got transferred up into labor and delivery where we waited for the doctor, and the doctor gave us some really hard news. He said, she's already kind of on her way, and maybe the best thing to do at this time is going to be to go ahead and deliver her and try again later. But that wasn't acceptable. So we had them transfer us to Florida Hospital South, where they actually have your high-risk pregnancy ward. And there we saw a doctor. The doctor took a look at her, and he's actually one of the best ones in this area, in the Florida area. Took a look at her, gave us a 50-50 shot of success. And they defined success as being carrying the pregnancy up to 37 weeks. So they kept her in Trendelenburg position, trying to keep gravity to keep the uterus down, try and aid in the procedure. They went through, and what they actually did was they dilated her completely and tried to massage the amniotic sac back inside. And they took the cervical opening and kind of pinched it closed, and it's called a rescue cerclage, and it actually kind of looks like that. If you can imagine, that's what they did to the cervix, where they wound some string all the way around it, pulled it closed and tied it tight. They actually did 2 of them on her. One was just a couple centimeters above the other one. And the doctor, when he was done, said it was the most aggressive rescue cerclage he's ever performed. We were in there for about an hour and a half. If you can imagine, this was actually performed on Debbie's birthday. So that was an interesting thing to say the least. But they did it. And we ended up on bed rest. We spent a few weeks in the hospital, and then we moved on to our place. 28 weeks and 5 days gestation. She had an intense abdominal pain. It was not set to any rhythm. It wasn't anything that we could time. We called this high-risk doctor that we'd seen the day before, and he said, you have constipation. Take something for it. So I went on a quest. Keep in mind at this time we don't have a car. I live across the street from my work, and we take the bus. Everything works out pretty well. So I go on a quest. I'm looking for prune juice and a very specific medication that our pediatric doctor, our OB, said that we can take for constipation for pregnancy. None of the convenience stores around me had it. So I ended up calling the cab, had him meet me on the way to Walmart, ran in real quick, grabbed it, came home. She takes the prune juice, she takes the medication, and it kind of settles it a little bit, but she still doesn't sleep that night. She's up all night with pain. And eventually in the morning I have to go to work, so I ask her what she wants me to do. She says she'll be fine. So I go off to work. At 5:45 I get a message from her that the pain is intense and she needs me to come home. I came home, tried to work with her a little bit. I sat her on the toilet, see if we could get anything to move, and we don't get anything. About at the end of my lunch, half an hour in, she makes the decision that this is not something she can handle when she wants to go to the emergency room. So we call 911 and I call work and let them know that something's not right and we're going to the hospital. Keep in mind, when I went to lunch, it was 5:45, so when I called the ambulance, it was about 6:15. At 6:54, Kyrie was delivered. It was an exceptionally fast labor. Actually, by the time she was pretty much done, the doctor had enough time to come in and say, "Hi, my name is," before the nurse rushed her off, or rushed him off rather, to go get his scrubs on. He went over there and said, "Give me one good push." And actually she took two because the first one startled her so much she stopped. And that was it. The big warning sign here that tipped the nurses off to what was going on, because they couldn't find any contractions on the monitor. They actually couldn't even find the heartbeat very well of the baby. But what Debbie said to tip them off is, "You're going to have to let me get up. I really need to use the bathroom." At that point, the nurse said, "No, sit right there." Went in to take a look, and the baby had actually broken the cerclages. Both of them had snapped open, and they saw hair in the birth canal. So this was us. 2 pounds, 12 ounces, 15 inches long, just shy of 29 weeks. We went from having a room full of nurses and doctors, we managed to get the right of shift change, to having a baby. When Kyra was going to be delivered, they said that the baby's not very developed, so don't be surprised if she doesn't cry. And as soon as she hit the table, she was crying. We went from all of that to me standing in a room by myself going, "Well, what do I do now?" They'd taken her out to do what they needed to do with her. My girlfriend went to the operating room to do a partial D&C, where they basically open her up and take everything out of the uterus except for the uterus to make sure that there's nothing left in there. What we found out from that was that she had what is called a complete placental abruption. Your textbook uses more of a Harry Potter term when they call it abruptio placenta. The book says that what you're going to expect to find that is after some kind of trauma. And that probably is going to be true most of the time. Please keep in mind it can happen spontaneously. My girlfriend spent a long time talking about the EMS that took her. Why didn't they do her faster if she was going to have the baby? Why didn't they go lights and sirens? And I told her, based on what we're taught, there's nothing to indicate that she was going to go into labor. She wasn't doing any of the warning signs that would have indicated that she should be in the hospital right then. Everything just worked out very lucky. Just try to keep an open mind. Just because you don't have trauma doesn't mean that you can't have that. I tried really hard to embed this video and it didn't actually work for me. So I'm going to play this quick video. This is the incubator that they transferred her to from Florida Hospital Winter Park to Orlando South, where they have the only actual level 3 NICU in the Florida hospital system. In the NICU, we had a little bit of complications, nothing horrible. If you ever spend any time in the NICU, it's a wonderful area where you have what I like to call quiet chaos. You have some crying, you have some monitors, and for the most part, everything is stable. But that changes very quickly. You have different levels that are dependent upon the baby's need, and we started off in a level 3 NICU. That's where the most complicated babies go. There's going to be fewer babies per nurse, and they're constantly being monitored. We spent a couple times under the light. It's an ultraviolet light for jaundice. There's a problem with premature babies where you don't actually start normal red blood cell production until about 35 weeks. Before that, you have immature red blood cells, which are supposed to be very efficient in carrying blood so that they can pick it up from the oxygen from the mother, but they don't live that long. So your body tries to break it down, and you don't have that many bowel movements, so it builds up in the skin. We spent 4 times under the light, and she actually loved it. We called those her movie star glasses. We got transferred to a level 2 NICU. Fewer nurses, babies per nurse, more stable babies that require less attention. There's a few things up here that I'm actually going to point out. You have up here is her hospital ID. Up these you have her vital monitors. This is actually kind of a cool little thing right here. I don't know how well you can see it, but it's kind of like a silver pad. What that does is monitor temperature and moisture, because the NICU, the isolates are a very controlled environment. The babies have to maintain a constant temperature and a constant moisture, so they actually have water running into there to provide the moisture. If the baby's temperature changes at all, the isolate adjusts it automatically. Actually taking the baby out of the isolate, they first have to take her temperature, and then they have to bundle her up, and then they give her to you, cap and everything, and check her temperature again every 10 minutes to make sure it hasn't dropped enough. And if it does, she goes back in the isolate. This is basically a baby that's not done cooking, and that's what she's trying to do right now. We spent 10 weeks in the NICU. At about 4 pounds and 8 ounces, 19.5 inches long, we were transferred to an open crib. This is actually one of the first outfits she wore. I have it with me. Before that, if you ever see the preemie shirts, take a look at that, because the first time we wore one of those, we swam in it. It was huge. They rolled up the sleeves. It was really loose on her. Just keep that in mind the next time you take a look at it. We were withdrawn from caffeine. They give premature babies caffeine to artificially keep the heart rate up and the respiratory rate up so they don't drop. We were withdrawn from that to make sure that that wasn't what was actually keeping our heart rate up. And we were awaiting the car seat test. The car seat test is kind of a cool little thing. They sit them in the car seat. Let's say what they'll be driving home in. They have to maintain their vitals for 1 hour. If you drop 3 times in vitals, they stop it right then and put them back in the crib. We failed 4 times. And eventually passed and got to go home. And this was us. We're still tiny. We're fed on a schedule every few hours, changed at the same time, but for the most part, not really all that complicated, and we didn't require any more care than a normal baby would, just some extra precautions. And then there were the 2 questions that changed everything for us. One of our pediatric visits, they asked if we had any questions, and the first one that we had was, why did she ball up her tiny fists until they turned blue? The other question that I'll get to later is, why does she violently throw up after her feedings? Those both led us to very long roads. But the first one, why does she ball up her little fist? The doctor looked at us and said, when she does that, what is she doing? Well, she's just kind of staring. She's just kind of looking off. Okay, well that sounds like seizures. So we had our first 1-hour EEG. Didn't find much. We didn't expect to find much. If you take a person 1 hour out of one day and you look for seizure activity, you're not necessarily going to find a whole lot. But insurance requires it to do a 24-hour EEG, and so we did it. And we had our first 24-hour EEG, where they hook her up, they have all the electrodes attached to her brain, all of her head anyways. They have the vital monitors so they can keep an eye on what's going on. They have cameras pointed at her constantly, so if they do notice a spike, they can see what she was doing at the time. And we wait for 24 hours. And we were diagnosed with epilepsy. We actually have just about every kind of seizure you can have. She has the absent ones where she just stares off into space, and you wouldn't be able to tell unless you knew what was going on to see when she was having a seizure. We have the tonic-clonic ones, the really bad ones where she'll start jerking. We have the myoclonic ones. These we just found out about recently, that these are seizures. The last 24-hour EEG showed this, where she'll be laying in her high chair sleeping and her leg will start doing this. And it turns out those are also seizures. We have generalized seizures, and actually we found seizures we didn't know were seizures. We have no outward appearance that they are seizures. For all we can tell, she's doing everything perfectly normal. And at the time that we saw these on the monitor, she was actually watching Doc McStuffins, having a good time. And the doctor pointed out her live feed for the EEG and showed there's one, and there's one. So we actually don't know the full scope of the seizures, except that we had more than 100 on the last 24-hour EEG. As far as epilepsy goes, in 70% of cases, there is no known cause. 300,000 people have their first seizure every year, and 120,000 of those are under the age of 18. Between 75 to 100,000 of them are children under the age of 5 that have a febrile seizure. And roughly 10% of new patients do not find control of the seizures with medication. That's where we sit right now. We're actually looking at the last form of medication we can go on, which is medication that's so rough it's going to take us 2 months to work up to a full dose. And if this doesn't work, then we start looking at brain surgery. Some concerns that we're going to have with this. When she has a lot of episodes, she can become very moody and agitated. No reason at all for it. In one moment she's up, and then she's down, and then she's playing with this, and then she wants back up, and then she's down, and she's probably crying the whole time. A lot of times when that happens, it seems to us like a buildup, where eventually she will have a large seizure, and she'll just stop. And then she'll lay down with her blanket, and she'll stay there for a while. Almost kind of like a reset switch. During that time, she can have a slowed heart rate or respiratory rate. Any kind of missed doses at all will show an increase not only in the severity but in the frequency of the seizures. We have, from the last 24-hour EEG, a last resort. They call it a wafer. It's actually a little pill that goes in the cheek of the mouth, kind of like your instant glucose, where it gets absorbed there. This is for if she's having a horrible seizure that we cannot get her out of and she is not breathing. We administer this, we hold her head to the side so she can't choke on it, and she either comes out of it or we call 911. Just so you know. Some questions that you're going to be looking for in the field if you ever do deal with this. Does the child have a neurologist? If they're having seizures and they have a neurologist, they probably have epilepsy. If they don't have a neurologist, they're probably febrile seizures. Are the seizures different than normal? How have they changed? Are they happening more often? How long are the seizures lasting? Has the child missed any doses of their medication? Here's another good one. Has the child been sick recently? If they've been sick, they may have thrown out their medication. Medication may have passed through them without getting properly absorbed. And does the child have any triggers? For Kyrie, flashing lights are a trigger. Stress is a trigger. So you can expect things like that. And if they're in an environment that they have a lot of their triggers, you can expect that might be a possible cause of it. This might not necessarily help you in their treatment, but this is going to be good information for the nursing staff at the hospital when you take them. When will someone call 911? When the seizures change or evolve, if they come more often than normal. if the seizures are not stopping, or the child is not breathing, or if somebody else witnesses it, they freak out, they call 911. For the most part, epilepsy is something you live with. It's not something that you're going to call 911 every time a seizure happens. Anyone who has epilepsy, and the parents are probably going to be pretty well rehearsed in it, and they're going to know what's going on. So you can only expect somebody to call EMS if something is wrong, if it's outside of what they perceive to be normal. The neurologist follow-up, we were diagnosed with epilepsy, we were placed on medications, and we were informed during the 24-hour study that she had stopped breathing during the night multiple times. And so that took us to a pulmonologist. The pulmonologist gave us our first sleep study. Very similar to an EEG, except there are fewer electrodes on the brain. But they still have all the vital monitors, they still have the camera, and what they're doing this time is they're looking to see how she's sleeping. They're looking for her to stop breathing. If she's going to stop breathing, they want to know what she was doing. They want to know if she was snoring, and they give a pretty good idea of what's going on. And we were diagnosed with sleep apnea of prematurity. That is defined by Medicine Plus as short episodes of stopped breathing in babies who were born before they were due. It is common in premature babies because either the brain doesn't develop properly or the muscles responsible for breathing are not properly developed. It's going to be short episodes, either 5 to 10 seconds, of shallow breathing or stopped breathing. They may have a drop in their heart rate. And episodes lasting longer than 20 seconds are considered serious. Usually they stop by the age of 1 year old. We did not. We actually are still going with our sleep apnea, and we haven't determined why. Ours has actually evolved where we're getting fewer respiratory alarms and more heart rate alarms, which has led us to a cardiologist, and that's something we're actually still working on right now. This is a picture of our apnea monitor, and that, I can tell you, was a very long night. The red light on the left is the heart alarm. It will alarm intermittently, where it will kind of tone in spurts for a heart rate of 60 or less, and it will go solid for a heart rate of 15 or less. The one on the right is the respiratory alarm, and it will go intermittently for any break in breathing for longer than 20 seconds. The yellow one on the bottom is the system alarm. That means that she might have had a loose cable, she might have kicked it out, any number of things. The green lights on the bottom are normal lights, actually. That means it's charging. Some special concerns with this. If the belt is loose, then it will show that she is having an apneic event. One of the first things we'll actually do if she starts alarming is redo the belt. You need to be able to slip 2 fingers underneath the belt with a little bit of wiggle room. Tighter than that is too tight, looser than that will read false alarms. The flashing lights on the front, right above the red alarms, there are flashing lights. The one above the heart alarm will flash every heartbeat. The one above the respiratory will flash every time she breathes. So it's going to show you a real-time display of what's going on. On the underside, there's actually an LCD display that will show you her current heart rate and respiratory rate numerically. That can be very useful. If you're out in the field, somebody's attached to a monitor, leave them on the monitor. Check out the monitor and see what's going on. Your book says that the monitor should have a pulse ox attached to it, and they should. Ours does not. So that's not always true. We're actually working on trying to get one of those right now. Just keep in mind, I don't know them all. I know ours, and they may or may not have pulse oximetry on them. System alarms can be one of several things. It can be a low battery. It can be a broken cable. I'll show you the cables in a minute, actually. It can be a full hard drive. Whenever she has an event, it actually records it so they can pull it off and send it to the doctor. It could be a moved sensor where it's not supposed to be, or it could just be a system error. This is going to be the belt over here. This is something she wears pretty normally. You saw a picture of her with it a little bit ago. These are the sensors up here. The one goes about here, the other one is about here. They connect with Velcro, and that's really as complicated as that gets, for the most part. Positioning is still difficult. These little cables right here go up to this guy over here. This is called a patient cable, color-coded so everyone can figure it out. There's one button for on-off, one button for the reset for the alarms. If she's having a current alarm, it will not reset until the alarm has stopped. And this is as complicated as it is. When she's asleep, she's attached to it. If we're out, she's attached to it. Mostly at this point to keep us aware of any problems and so we have a better picture of what's going on so we can send the information to the doctors. I will have this up here as well as everything else. If anyone has any questions after it, I'd be more than happy to answer them. This is a pretty basic example of the position of the monitor. Actually, ours is on top of the dog kennel. When will someone call 911? Child can't be awakened, still is not breathing or has a low heart rate. Keep in mind that any parent that goes home with one of these is trained in CPR. So by the time you get there, they probably already starting chest compressions and telling you what's going on. And then we got to the other question. Why does she violently throw up after her feedings? This isn't just once or twice. Babies spit up. And actually, one thing you're going to notice about Kyrie is that she has a lot of things that you're going to say, well, my child does that. My child throws up after she eats. That's pretty normal. Mine stares off into space. It's okay. There's no one specific thing by itself about Kyrie that indicates that she's special needs. But it's rather why she does it. And it's the collection of everything that makes us where we are. So we asked, why does she violently throw up? We were told to go to a surgeon. The surgeon would take a look at it and see what he thought. The surgeon's recommendation was something called a Nissen fundoplication, where they will take the fundus of the stomach, wrap it around